My name is Dr. Sharon Parrish. I'm a professor of clinical medicine and clinical psychiatry at the Weill Cornell Medical School in New York City. I practice internal medicine and sexual medicine in men and women. Female sexual dysfunction is a spectrum of disorders that affects women of all ages and across all ethnicities and social groups. It's related to problems of sexual desire, arousal, orgasm, and pain. This is an important issue because sexual problems are very common. Sexual problems affect somewhere around 40% of women, and about 10 to 15% of women are distressed by these sexual problems such that they would like a remedy. Often they would like to have help from their clinician. Women are very reluctant to bring this up in the clinical setting because they feel embarrassed or they're concerned that their clinician might not accept the question or it might not be appropriate to raise it in a clinical encounter. The symptoms of female sexual dysfunction depend on the phase of the sexual dysfunction cycle that's affected. That might include problems with desire, arousal, orgasm, or pain. They may occur separately or they may be co-occurring. The symptoms of low sexual desire include a loss of enthusiasm or interest in sexual activity, low motivation for engaging in sexual encounters, and sometimes low receptivity. This can be very distressing to women because they feel that they somehow have lost their sense of femininity or their sense of enthusiasm for connecting with their partner. The symptoms of low arousal may involve a sense of low subjective excitement, that is, feeling of stimulation and that emotional and psychological sense that people get when they're aroused, or they may lose the sensation of genital arousal, where they actually feel a loss of sensation or lubrication in the vaginal area, the vestibule, the vulva, that is really part of a robust sexual response. Orgasm difficulties are generally experienced as a genital phenomenon, where a woman may experience in total a loss of orgasmic capacity, or it may be experienced as muted, diminished, truncated, painful, or too soon or too late. Women can sometimes identify them as causing one another. In other words, a pain problem may cause low desire, but often they see it as a blend or a mixture of these problems all at once. Sexual problems can be very distressing for women. They can impact their quality of life. Specifically, women complain of the effect on their relationship, on the effect on their partner's perception of their enthusiasm for them as a sexual partner and for them as a partner in general. It may lead to feelings of low self-esteem, loss of femininity, even very more dramatic symptoms like helplessness or hopelessness about the future. HSDD is characterized by often low drive or low libido, which may be characterized by low initiation, low motivation or lack of motivation to engage in sexual activity, and lack of receptivity to partners' interest in having sexual encounters. HSDD may lead to low levels of confidence, decreased mood, loss of self-esteem or sense of femininity. It also may have a significant impact on the relationship with a woman's partner who's affected by this condition, and may therefore have a very negative effect on quality of life. Distressing low sexual desire is the most prevalent sexual disorder in women of all ages. While desire problems increase with age, distress about low desire decreases with age, so this is actually a problem that's relatively constant across the ages and affects somewhere around 10 to 12% of all women. These barriers include lack of time, lack of knowledge or training in sexual disorders and their treatment, reimbursement issues, coding issues. They may have personal issues with talking about sexuality that may not be an area of comfort. A clinician may suffer from what we call ageism. In other words, they don't believe older patients have sex, or they may have biases or negative attitudes toward people with alternative sexual behaviors. They may not endorse homosexuality or polyamory or other variations in sexual behavior. Identification and diagnosis of FSD in patients can be improved in a few different ways. Firstly, I think there needs to be increased patient awareness or patient education, and this can be done through pamphlets or in physicians' offices or questions on intake forms. as well as patient handouts that patients are given as they leave the office. To improve identification and diagnosis of FSD in patients, clinician behavior really could play a very big role in improving the detection. Clinicians need to ask screening questions, general questions that allow women to know that this is a topic of discussion. They can focus on the specific life phase or experience of the patient, such as childbirth or menopause, and relate it to the possibility of changes in sexuality. Intake forms could have questions about sexual dysfunction and give the message to patients that the topic can be raised. Clinicians can also engage in programs that offer education that can raise their knowledge base about sexual disorders and their management. Women often feel when they have low sexual desire that it's a bit mysterious. What happened when I used to see my partner? I used to get excited or hot when he walked in the room, or she would feel anticipation about the possibility of a sexual event in the near future. And women will say that feeling has just gone away, that urge, or that drive, or that enthusiasm, and they find themselves, in fact, sometimes even being avoidant of the possibility of sexual encounters. And women often see this as very mysterious. What happened to it? I don't know what happened to it. They may have concepts about contributing causes or factors such as high levels of stress, competing responsibilities to their family, to their partner, to their children, to their career, maybe other priorities like making time for themselves, making time for exercise, having other obligations. Women who lose desire often feel that the loss of desire is elusive. They feel that something is missing, a part of them is gone, they don't feel whole anymore, and they want to get it back. The identification of themselves as a complete woman, their sense of femininity was closely tied to that feeling of wanting to be sexual and be enthusiastic about their sexuality. Women have theories about where it's gone. Some women believe that it's a normal part of aging and that they have to accept it. And so when they may have that idea that that's why they don't either have time or interest in sex, but they don't see it often as a real, like a condition that could be diagnosed and treated in a medical setting. There's a low recognition of that. And that they come to the point where they just say, oh, well, I have to learn to live with this. This is the way it goes. Women also sometimes don't seek treatment or really think about what to do about low desire because they believe it's temporary. Maybe it has to do with a stressful time at work, or say a loss of a parent, or some struggle that a child is having in school. And they don't see it as something that will continue or persist or going to be global or pervasive in their relationship. And then when the condition carries on for a while, they just sort of accept it and they don't engage with seeking treatment. The downside is that it can be very distressing, very detrimental to their own inner peace, happiness, sense of wholeness, and certainly to the dynamic in their relationship. When patients notice a change in their sex drive, they're very bothered by it. And they may come to me because somehow they know that talking with me about this may be helpful, but I don't believe that they're seeing it at the onset as a medical condition. In general, there's very low knowledge among patients in the community about HSDD, and so the concept isn't very well organized. This is a medical condition. What they do know is that there's a change both in their subjective sense or perspective on or perception of having a sex drive, and their ability to be responsive to opportunities with enthusiasm. When a patient comes to me with bothersome low sexual desire, the first thing that I do is talk with them about the potential contributing factors that they perceive may be impacting their desire and in my clinical assessment are important. And I look for those factors that may be amenable to intervention. I explain that low sexual desire may be related to life stressors, the interpersonal relationship, and sometimes we have to do a medical evaluation for certain medical conditions. When I explain low sexual desire to a patient, I really emphasize that there are biological, psychological, and social or cultural factors that affect a woman's ability to experience desire and respond to it. I also explain that when this condition occurs, particularly HSDD, there's a disconnect between someone's idea about what should be and what they actually experience, and also a disconnect between their mind being able to generate desire and their body being able to want desire, and them actually executing it. Regardless of how a woman gets to a state of having low desire, the experience of low desire can become patterned or imprinted in the way that her brain processes information. And therefore, low desire may be amenable to biological interventions. I would like to really emphasize that female sexual dysfunctions, hypoactive sexual desire disorder, and other sexual problems in women are very important for women. Women have not had a lot of opportunity to discuss these conditions and to seek treatment and receive appropriate remedies or interventions in clinical settings over several decades, whereas men have had many treatments available. This is due to low awareness in patients and low recognition of clinicians or time on the part of clinicians to detect and manage these conditions. By not addressing this in our practices, we're doing women a huge disservice. Clinical settings, particularly primary care and gynecological settings, are the place where women could really receive help and treatment, and we're doing them a disservice if we can't learn to do this well and offer these opportunities for discussion and treatment to our patients.